everybody. I think we'll just make a start. I know that time is precious and many of you are, it's a work day for all of us, and we're fitting this in often into our lunch hour, and thank you for giving that up. But it's really to promote discussion on, challenging issues in ethics, and this is the Ethics Exchange, where today we're concentrating on consent in challenging circumstances. The first thing to do is to welcome everybody in acknowledgement of country. I'm sitting on the UTS site, so I would like to acknowledge the Gadigal people, the Eora Nation, upon which these this now stands, this site now stands, and pay respects to elders past, present, acknowledging them as the traditional custodians and of knowledge for this land. Always was, always will be Aboriginal land. I'd also like to acknowledge the traditional custodians of the various ancestral lands on which all of our attendees are joining us today, and pay respects to those elders past and present as well. Just by way of background, I don't know how many of you are aware of what the Research Translation Centres and Sphere as a Research Translation Centre is trying to do. Maradilu Bidyari Gamal is one of the 3 New South Wales Health Translation Centres, and we have 15 partners across universities, local health districts and medical research institutes that deliver innovative health research to address these processes that underpin the conduct of our research. So we wish to streamline, certainly relevant to this meeting, is to make research easier to do. So while we want to collaborate and amplify and translate and impact at scale are all very, strategic intents, the purpose for today is to really make research easier to do and streamline some of those wicked and challenging problems inside research ethics and governance. So the Ethics Exchange is a joint initiative of Sphere and the ethics units across its partners to facilitate sessions that, jump into these common and challenging aspects of human research that everybody struggles with, and hopefully we can workshop to improve outcomes. The sessions are recorded and will be held on the Sphere website for future access. And in 2023, there are 3 sessions that will be being held. So this session is the consent in challenging circumstances, and the August session will be paediatrics and children in research, and the October session will be registries and ethics review. So I think some housekeeping is required, and so I'll just I reiterate that it is recorded, and the recording will be made broadly available, so you can come back to it later or refer others if we kick it out of the park and there's stuff in here that you really find useful. But the real thing we want to promote, and it's always easier if everybody's in the room, but it's hard to get everybody else in the room, so we're doing it virtually, is to promote discussion. And so use the chat function to ask questions. If you're not confident or comfortable just, unmuting and asking a question later, then, or as the question comes to you, just use the chat function. We'll monitor that, and we'll either, open it up for you to ask that question at the appropriate time or ask the question on your behalf. But it's really just to promote discussion and get that chat going, right? But we will mute during the session unless asking a question. Statistics from the day will be used for reporting purposes, and identifiable information on attendance can be shared between ethics units if you wish. So that just leaves me to introduce the 3 speakers who have kindly given up their time. And we have Kirsten Boggs as a Senior Genetic Counsellor from the Australian Genomics based at Sydney Children's Hospital Network. And thank you, Kirsten. You're presenting on is there such thing as informed consent and the lessons learned obtaining consent for genetic and genomics testing. Jennene Miller is a research CNC in ICU at Liverpool. Jennene, I think we met when you were at St George back in the distant pre-COVID days. And she's working with Liverpool Hospital and will be covering challenges in informed consent, clinical research in intensive care, which will be certainly very challenging. And Bronwyn Hemsley is the head of speech pathology at UTS and co-lead of the UTS Disability Research Network. And so what are the complexities in consent when there is disability, communication and inclusion? So they're 15-minute presentations followed by 5 minutes of discussion. And after all three presentations, we hope to really ramp up the chat. And one of the measures of success will be the robustness with which we have that engagement and interaction as a consequence of the presentations. With that, can I hand over to Kirsten, who I have introduced, but will be presenting, is there such a thing as informed consent, lessons obtained from consent in genetic and genomic testing.
Thank you, Chris. I will share my screen. Hopefully this works since we just practiced and it looked okay. How's that for everybody? Good? Okay. So hi everyone, my name is Kirsten Boggs. I am a senior genetic counsellor working for Australian Genomics, but based at across Sydney Children's Hospital Network, and I'm here to talk to you today about informed consent and some lessons that we have learnt from obtaining consent for genetic and genomic testing. So I'd also like to acknowledge the traditional owners of the lands in which we are all meeting today. For me, that's also the lands of the Gadigal people of the Eora Nation, and I pay my respects to elders past and present and extend that respect to any and all Aboriginal and Torres Strait Islander people here today. I'd like to acknowledge that sovereignty was never ceded and that this always was and always will be Aboriginal land. So I guess just to start off with, to give a bit of background about what genetic counsellors do. So essentially we talk to families about genetic conditions and we work in a variety of settings across adult medicine, paediatrics, prenatal, cancer, and then increasingly in research settings. So for myself, I work across paediatric and research. So really our role is to help families adjust to the possibility of a genetic condition being present in the family. And we also help families make difficult decisions about whether to proceed with genetic or genomic testing. And then based on that decision, sort of the next steps for them, particularly, I guess, if there is a genetic diagnosis made in a family, then there can often be health management implications and decisions that families are required to make based on those diagnoses. We take families through a very tailored consent process. And what I mean by that is that we speak to families to really understand their background and where they're coming from, so that we can make sure that their understanding of what they're saying yes to in terms of genetic testing, that they understand the concepts at least to be able to make a decision. We manage expectations for families around testing, and we discuss the possible implications of genetic results as well. So how do we approach consent? Obviously, genetics is full of very technical, scientific, horrible language that most people have no shot of understanding. And so really we need to balance that information giving to families so that they can, I guess, make as an informed decision as possible. So it's really about thinking about what their information needs are and then making sure that the concepts are discussed in a way that they are able to make a decision about whether to proceed with testing or not. And I guess really this also talks about different environments that would call for different approaches for families. And what I mean by that is in genetic and genomic testing, and sorry, I should qualify, when I say genomic, I mean testing lots of genes all at once, which is kind of more my area of expertise. So there's really different environments where we offer testing And I guess as an example, a genetic counsellor might meet with a family or a patient that has a family history of Huntington's disease, which is an adult onset neurodegenerative condition. Generally, those patients will have a family member that has been diagnosed with Huntington's disease, usually a mum or a dad. And then they themselves are at 50% risk of having the condition. And so genetic counsellors would meet with that person to discuss testing. Now, obviously, that's predictive testing. They don't yet have symptoms, but they're going to find out that essentially they have a genetic change, which means they're at risk of developing that condition, which is fairly confronting, I think, for most people. But I guess a genetic counsellor in that circumstance would meet with a patient multiple times. They would have lots of time to work out a patient's mental health, work out where they're coming from, what their value system is, and really sort of tailor that approach to them and work with them to work out whether testing is appropriate for them. Versus, I guess, where I've come from over the last 4 years, particularly, I've been working very closely with families who have children, critically unwell children in paediatric ICU and in neonatal ICU. And I've been talking to families about genomic testing, so testing lots of genes all at once to try and find a diagnosis for their unwell child. Now, you can imagine those environments are quite different and have their own unique challenges, but I guess the ICU environment is obviously fairly traumatic, and having to kind of convey all of this information to people to help them make a decision when there's lots of other decisions to be made and things going on can be quite challenging. And I will talk more on that later. So what do we actually talk about when we're obtaining consent from families? So sometimes, depending on the family's background, we'll give them a bit of a genetics or biology lesson. We talk to them about types of results that might be expected back. So either we'll find a diagnosis, we may not find a diagnosis, or we might find something called a variant of uncertain significance, and that is where there's a change in a gene where we can't quite explain what it means at this point in time and will lead to more uncertainty for the family. There's also a huge emotional impact if there's a positive diagnosis made, although sometimes if we don't find something, that can also have an emotional impact. And particularly, there's a lot of guilt and shame around genetic results. And of course, genetic conditions are often not treatable or not curable. So that can be quite devastating for a family. We also talk to them about the possibility, particularly if we're doing large-scale genomic testing, that we might uncover unexpected family relationships. And so one of those things would be what we call misattributed parentage, so either non-paternity and to a lesser extent non-maternity, although that can happen. And I guess it's reasonably common in that probably every genetic counsellor that I have met has had at least one case where there's been either non-paternity or non-maternity uncovered. And then also unknown consanguinity. So that would be where, I guess, in a couple relationship that they may be more related to one another than they previously thought. We also talk about insurance implications. So for health, not for health insurance, but for life and income protection insurance, there can be implications for insurance premiums, depending on whether you have a genetic diagnosis or not in the family. Increasingly, this is becoming more and more important as we talk about data storage and privacy. So who has access to the genomic data and how is it stored? And then for me, so that's all for clinical testing. And then once you start getting into research, then you also need to talk about the research implications. So what is being studied, where's the data being stored, all the usual research consent along with all of that. So it can be quite an intense information overload for people to go through all of that in a conversation. So where Australian Genomics comes into this, really, I guess we have been around since 2016. We do have NHMRC funding until the end of this year, although that will probably hopefully be extended in some capacity. And we started out as a national program. We were actually offering mostly clinical genomic testing as part of kind of research sub-studies called flagships. And we were looking particularly at rare disease, cancer, and reproductive carrier screening for the 3 broader flagships that we were offering enrolment in research and testing for. And I guess really what we were tasked with was to build Australia's research and research translation capacity in the area of genomics and healthcare. And so one of the challenges that we noticed fairly early on was thinking about the consent process, not just for genomic testing, but also adding on that extra layer of I guess, research on top of genomic testing, and how tricky that is to navigate with families who, I guess, we're approaching to be part of the study. So the first iteration of Australian Genomics, where we were recruiting our own patients, we recruited over 5,500 patients for genomic testing across the country. We had 32 recruitment sites, so pretty broad national study. We've now sort of moved into this more advisory role where we're not recruiting our own patients, we're actually giving advice to genomic research projects across the country to kind of help them, I guess, do things in a more cohesive way. So when we were thinking about how to approach consent, so when we first started out, we were giving families the 16-page participant information document, and you can imagine particularly seeing families up in ICU, that potentially was not actually that helpful to give them a 16-page document that outlines genetics, genomic testing, and research. Now, obviously, we understand that that's an ethical requirement from, from the HREC committees. But we thought maybe we could develop some kind of summary document to help families kind of have something to refer back to. And so along with that, and thinking about this approach, Australian Genomics has developed a couple of tools that I'm going to very quickly run through now, and happy to take more questions on to really help that consent process. So the acute care study, which I'll go into in a moment, we had a 1-page consent summary document, and we also ended up using e-consent. We also developed, as part of Australian Genomics, an online consent portal called Control, and I'll take you through that as well. There was an online decision aid that we used called Genetics Advisor, and then we also looked at a national standardised genomic consent form. So the acute care study, which is where we were offering genomic sequencing to families where they had critically unwell children in NICU and PICU across the country. I could talk about this study for hours, but essentially we had sites across the country and we were offering rapid genomic sequencing. So what I mean by that is normally genomic sequencing, so testing lots of genes all at once, takes, from a number of weeks to a number of months. We were getting results back to people within sort of 3 days, because obviously there's critical decisions to be made about a child's healthcare. So that was a national study that I was involved in. And essentially we developed, because we were, as I said, initially going up and seeing these families with this sort of 16-page participant information consent form, we developed a summary document, which was a 1-page sheet that just had the really key outcomes of the research and what we were looking for. And that there's an example of that on the right-hand side. And that actually we got fantastic feedback from families that, that it was helpful just to have that to refer to. And then obviously if they had more in-depth questions, then we would go and see them and talk them through that. We also developed e-consent online, so using the REDCap database, we ended up being able to do e-consent, we would take either a laptop or a tablet up with us to see families and go through the consent online with them, which actually turned out to be very, very useful in 2020 when COVID became an issue, because we were still able to consent people, you know, without actually having to meet with them face to face if there was an issue with that. So that was incredibly helpful. We also collaborated with Genetics Advisor. So this is a Canadian group who developed this tool. It's an online decision aid and basically takes families through scenario-based questions as to, you know, are they leaning more one way or the other in terms of saying yes or no to genetic or genomic testing. So they go through it as them whether they're sort of leaning more towards saying yes or no to testing. So that, again, we're about to publish our work on this, but again, people found that incredibly helpful to kind of, I guess, get them thinking about their choices and their values. And lastly, just to talk through dynamic consent. So this is the online consent portal that Australian Genomics developed called Control, although there are a number of other dynamic consent portals in use around the world. And really, this is a way of maintaining communication with families and research participants with an online tool. And I guess part of that was about developing trust in research and with sharing of health data. So basically, participants can go in, consent, but then they can actually go in and change their consent options as, you know, their circumstances change or as the years go on. So again, people have found that incredibly helpful. There's some examples of different dynamic consent portals in use across the world. So there's Control, our one, which has been used by a number of different sub-studies listed there, and then obviously some others in the UK, the US, and in Italy. I guess a role for this when there are challenging circumstances in consent, when we're thinking about research, and not just in genomics, but in general, I guess when information delivery is best spaced out over time, or if participants have higher information needs. So obviously that won't be for everyone, but I guess if there are people who are concerned about privacy or data sharing particularly, then this kind of tool is useful for them. It's also useful for people who, you know, if you're recruiting large studies of people across a vast region like Australia, and we've certainly taken advantage of that through a number of different studies that we've been involved in. Also, I guess, particularly for paediatric research, when we're thinking about consent in, you know, children who are under the age of 18 and then they're going to be turning 18, it's a good way of getting updated consent from those participants once they're able to consent for themselves. And then lastly, just to finish up, just to mention that there's also a national consent working group led by Australian Genomics. So again, this is for genomic testing and basically trying to get some consistency in genomic consent forms for both clinical testing, but also for research testing as well. And that's the group there. I guess the key issues have been that states and territories have a really individualised approach to genomic testing, and this is a barrier for the flow of health information, but also causes inconsistency to the patient experience. And so this working group have been tasked to kind of create a national form, which has been implemented with varying degrees of success. And they're continuing to work on a second iteration of that form because there's been developments in data and sample storage requirements, withdrawal of consent and future research options. So that will be happening. Hopefully the next iteration will be out soon. So thank you to the Australian Genomics team. This is just a picture of some of our team who helped me with some of these slides as well. And I'll stop there if people have any questions, or if you don't want to ask a question today, you can email me or follow me on Twitter. And I will stop sharing.
Thanks very much. So just the They're open for questions that anyone might have. Right.
I see there's a question in the chat.
Fantastic. No, look, I was just, that was actually my question, which was a memo to myself, which was, so Kirsten, thanks for that. How would you ensure, so in the study that you were talking about, how did they accommodate where English is not your first language?
Yeah, great question. So for some of our studies, so particularly for the acute care study where we were seeing families in ICU, we had access to interpreters. So we would actually meet with those families with an interpreter to help us. So the annoying thing was
how did you know the interpreter knew it?
Sorry?
So you'd actually have to have interpreters who were quite skilled at this.
Yeah, so this was part of, we were recruiting through a hospital. So these were medical interpreters that interpret complex information anyway. But I guess what we didn't have was access to translated material. So that one-page summary document, unfortunately, our study had no funding to translate those materials. A second study I was involved in, which I sort of didn't really mention here in the interest of time, but was the Mackenzie's Mission project. So that's where we recruited 10,000 couples across the country and offered them reproductive carrier screening, so to see whether they're at increased chance of having a child with a genetic condition. So we had an online consent portal using the control model, and we translated that portal into Arabic and into simplified Chinese. So we had access to translated materials for those two languages. And then for any other language, we would have to meet with the couple, usually via Zoom, to take them through it with an interpreter, which was obviously quite labour intensive, but we were certainly keen to get representation from ethnically diverse communities. So
you got data on that?
Definitely.
I'm going to assume that you were underrepresented in CAL.
We were.
Okay.
Yeah.
And how did the ethics committee manage that complexity?
They were quite happy with our approach, particularly, I guess, the translated materials, because obviously, a lot of studies come through, and I say that I also sit on a HREC committee. So a lot of studies do come through without funding for translated materials. So I think the fact that we had that built into our funding model, they were quite happy with. But certainly, I guess trying to get representation from lots of different backgrounds was incredibly difficult. So yeah, particularly for a large scale project.
Okay, anyone got any other questions to ask? Gosh.
I've stunned everybody into some.
You've stunned them.
It's Jennene.
Jennene.
I've got a statement actually. It's very good. Thanks very much for your talk. We did the same thing for COVID study. We got translations of our consents for the population that was coming through our intensive care. And I thought that we got about 3 or 4 of them who obviously were able to read the consent, and it was the correct translation, and it was HREC approved. But I found the majority of the actual people that were coming into ICU were illiterate, and they couldn't read their language. So they could speak it quite well, but they obviously just couldn't read. So that was actually quite a revelation for me. So it was just another hiccup that we had to contend with.
We learnt that too, particularly for Mackenzie's, is that a lot of languages, I guess, are more like a spoken language than a written language, and how to combat that when you have very limited resources to sort of meet with people with interpreters, it's incredibly challenging.
Thank you very much. Well, on that background, yeah, anything else? Other questions? Is it Bronwyn? Anyone? Other questions? Oh, here we go. Pamela, so the genetics moratorium on life insurance ends in June 2024. Can you give us an update on it being extended, please?
Yes, so for those who don't know, the moratorium is basically an agreement to say that insurance companies cannot discriminate for insurance, for life insurance and income protection insurance for people who are found to be at increased risk of developing genetic disease. So there's been people who have been working very hard in the background to extend that. I suspect it will be, but you know, there's still a lot of work to be done. So there's a whole team led by Dr. Jane Tiller down in Melbourne who are working on that. Unfortunately, at the moment, it's still sort of regulated by the insurance companies themselves. So it's kind of up to them as to whether they agree to it. But certainly it's an area of genetic discrimination that's been on our radar for some time, and really trying to fix that issue, because obviously if you know that you're at risk of developing genetic disease, you're more likely to make changes in your life that actually reduce your risk, more so than potentially a population risk. So anyway, watch this space, but yes, there are people working on that to extend it.
Okay, but that actually raises a good point to the team managing the. If we've got everybody on mute, does that mean people can't ask questions other than through the chat? Is that what is happening there?
People can unmute if they wish.
Okay, great. Just unmute and ask a question if you feel so inclined. That's fantastic. Okie doke. Any questions, comments, queries, anything else? Anything else happening there? Okay, I'm just going to executive privilege and just introduce Jennene, who has also indicated the complexities in the intensive care and some of the challenges in informed consent for clinical research in intensive care. Welcome, Jennene.
So I acknowledge the traditional custodians of the land. Here at Liverpool, it's the Dharawal people of the Eora Nation. I pay my respects to the elders past and present. So I'll be talking about today obtaining informed consent in intensive care. Thank you, Sphere, for allowing me to give this talk today. I'll be discussing my experiences and challenges of consenting in intensive care at Liverpool, which is a very dynamic and very busy adult tertiary university hospital. So firstly, I'll just be talking very, very quickly about what the definition of informed consent is and the NHMRC regulatory guidelines. I'll give you an overview of the ICU patient, and I'll summarise the ICU consenting process, and I'll outline the challenges and implications of consenting in ICU. So, in a nutshell, the NHMRC definition states that consent is a person's or group's agreement based on adequate knowledge and understanding of relevant material to participate in research. So we all know these guidelines. Then the National Health and Medical Research Council statements that provide a guidance to the requirements of consents in research, and they state that the consent should be voluntary. It should be given with sufficient information and understanding of the risks and benefits of participation. And now, informed consent is one of the most important aspects of research ethics, and the focus is on ensuring the rights of the patient. The most important ethical principle is the protection of the autonomy of our patients to maintain their rights and safety and well-being whilst participating in research. So the NHMRC also provide us with a statement that outlines the provisions for the consent process in emergency ICU and in particular research in unconscious patients, which you'll all be absolutely familiar with. So to start with, our prior written informed consent is our golden standard. And it states we should try and obtain and gain consent where possible from our patients. Unfortunately, this is a little bit difficult in intensive care. So what we have is we have a provision of a waived consent in emergency, and that's obviously following NCAT and HREC approval. So that's done because of the urgency of these interventions. We then have a provision for substitute consents, and we use that when our patients are unable to consent. So hopefully we'll be able to consent them pre-randomization, but we have the ability to do it post-randomization, but only if the patient's unconscious and if the research actually is minimally invasive or has therapeutic or benefit. So overall consents, we must avoid any additional stress or emotional stresses, and obviously avoid dependence of the patients and their families on treating clinicians, sorry. So I'm just going to talk to you about the consents in ICU and the 4 ones that really relate to the randomized controlled trials that we do. Obviously, we do have other consenting models, thus being, a waiver of consent and opt-out, but obviously they're usually for observational type studies, but I'll be talking about randomized control. So we have the 4 consents here, and it's a prior consent for the patient, prior surrogate consent, and they've got various names in various jurisdictions. It can be like person responsible or proxy, just depending on where you live. So for emergency and standard comparative treatments, we have waived consent, and that gives us provision for consent to continue for the patient, a consent to continue for the next of kin or person responsible. And a big shout out to all you ethics and governance managers out there. During the COVID response, we got verbal and e-consents approved for our COVID studies. So big thanks, because you're able to fast track our COVID research and give us speedy approvals, which allowed for the modification of our consenting processes at the time. So there were some delays, although we won't hold you to it because lots of your staff were deployed to other areas of the hospital. But thanks for having the insight, and otherwise we wouldn't have been able to actually recruit our patients into the studies without them. So this is just one of the consenting processes, and this is really quite well established in ICU, the use of those 4 consents processes. And one of the studies from the ANZEX clinical trials group called FluidRes, it's a comparative effectiveness trial. They basically just went through and did a flowchart for us, which is quite good in representing what we actually do in ICU. So basically, just to explain this flowchart, when I go to do a consent for the patient, I first look in ICU at the patient's neurological capacity, and I look at anything else that may impact the research and the ability of the patient to gain informed consent. So this starts here quite nicely in the pre-randomization of the patients. I've actually split it in 2 slides because it's quite big. So what we do is I look at the capacity of the patient to provide informed consent, written consent, and if the patient doesn't have that capacity, I look towards the substitute consent maker. So no capacity, go to the substitute consent maker. If the substitute consent maker is available, then I will get the substitute consent. If actually at the beginning of the start of this, if the patient actually is able to give consent, then I'll get it from the patient first, but then that's not usually the case. So secondly, we go to the next of kin. If, let's say, the next of kin's not available, we usually get provision of waived consent from the HREC, and they allow us to randomise the patient. So this is in the randomisation phase. So let's say the patient still hasn't regained capacity, and we have a next of kin so that we can get a next of kin consent to continue in the study. If, let's say, we don't have a next of kin, which is probably a little bit of a problem, but let's say the patient still hasn't recovered capacity, then ultimately we can try and get the HREC to give us approval for the patient's data. Let's say the patient actually dies, we won't go back to the next of kin and get consent. So we'll always go to the HREC to ask them for the study related information and consents. So it's a bit convoluted, but that's the hierarchy of the consents in ICU. Now, this is the intensive care patient, and this patient here, like, you might think it's actually a dummy, but it's actually not a dummy. It's one of our patients that was enrolled in one of our studies in 2021, and he came in with COVID pneumonitis. So he's actually ventilated, he's sedated, he's nursed on his stomach, so he's in a prone position. And he's obviously in one of our isolation rooms. So as you can imagine, trying to gain consent for our patients is quite difficult, and it's extremely sensitive in nature. And if you're thinking about it, this is the worst time of the patient's life and their relatives, basically, and we're asking them to participate in our consent, in our studies. So it is quite a difficult conversation. So during the time through COVID, we weren't allowed to have any visitors. Most of our next of kins were infected by COVID themselves, so they were spread out throughout the hospital. We weren't even allowed to have paper in the ICU, so this affected our consenting ability quite dramatically. So just to talk about the actual patients themselves, these patients are obviously in the vulnerable population category, and due to the fact that they don't have the capacity to give consent. So majority of our patients always have impaired capacity due to the nature. They're unconscious, sedated, they're usually intubated, and usually the nature of their illness or disease impairs them from having capacity. So I think my most important job in ICU is basically assessing the decision-making capacity of our patients and assessing it quite regularly to see whether it obviously alters and changes throughout their time in ICU. I think the screening for our patients' eligibility is quite essential, but obviously the inclusion exclusion criteria are quite extensive, and they exclude people who won't benefit from our studies. And obviously the first intention here is to do no harm. So we follow a massive consultation process with our intensivists. We collaborate with the whole team. And if it's not in the patient's best interest to be in a study, then we won't proceed to recruitment. So this slide here is me trying to portray and have all the balls juggling in the air and trying to portray all the challenges, but it just turned out really manic and crazy slides. So I was trying to relay the whole decision-making processes, and it's being affected by all these confounding challenges, including the patients being sedated, they're delirious, they've got pain, their fear, their age, their frailty, medications, they're ventilated, and many more. And some of these problems are modifiable, like decreasing sedation and extubating patients, and then non-permanent, but a lot of these things that affect the decision-making capacity of our patients are actually permanent. So I sorted this slide out a little bit better for you, so I'm hoping that you'll be able to actually get the gist of all that, these challenges. So I pretty much put it into the slide of, the the 4 slides, demographic and logistic challenges that we have in ICU. So Liverpool is one of the biggest ICUs in New South Wales. We have huge population, and we have high admissions with high mortality and morbidity rates. It's a large population, and our catchment area is quite extensive. So patients may be separated by their family, either if they come from rural areas or if they have their families overseas. So 50% of our families, our patients come from overseas and are from non-English speaking backgrounds. And what that means is too, that we do have a low medical literacy rate. And we have a large cultural diversity within this population. So talking about the interpreters, the availability of those interpreters is quite limited, and we're lucky if we can get the interpreters to speak the same dialect as our patients. So we go on to the communication challenges, and obviously ICU is really noisy and busy. In Liverpool ICU, we've got an open ICU, which is not very private. We find it difficult to really schedule convenient times because we have a lot of interventions happening in ICU, and times where they're free of interruptions is quite rare. So we understand that majority of our relatives come in here stressed, anxious, overwhelmed, like completely sleep deprived, and to also make things difficult, our patients are usually either ventilated, sedated, they're fearful, they've got pain, and all the above. They're stressed out, the whole bit. So all these conversations for research usually require multiple attempts to build rapport and to gain some understanding of what we're actually trying to do. It involves like massive team collaboration, and obviously in ICU this is all time restricted because we have all these time restraints, and it becomes a little bit difficult. So what we find here in Liverpool also is that our interpreters, get back to the interpreters again, the accuracy of the medical translations are potentially not up to standard, and we're not getting the understanding reflected in the patients. So they really are finding it difficult to understand the content of the actual concepts themselves. Through COVID, we found that a lot of our next of kin and our patients had huge medical mistrust, and there's a lot of false information. So we had to provide a lot of support and justification for why we're actually doing a lot of our research, because there was an obvious imperative that we get answers for potentially COVID, and that in itself was quite demanding, and our patients were difficult to win across. So any case, so a lot of these studies are quite complex, and REMAP-CAP was one of those that had multiple interventions, and those discussions were quite long and really quite technically difficult. So as I said before, we required a lot of specific brochures in different languages to try and compensate for their need for information. But what we also found too was that that need for information was quite immense, and that we had to really make sure we had the availability of our research staff and our medical team to provide ongoing information and ongoing education, which really was quite difficult, and we couldn't really do it and be sustained for 24/7. So surprise, surprise, we have a fair few social challenges. A lot of our patients come from large families, and it's difficult identifying appropriate decision makers. It's difficult even getting consensus from a lot of the patients. No one wants to really be responsible for making a decision. So there's lots of family dysfunction and estrangement, very minimal social supports, and we get a lot of people who are drug abusers and have social and mental health problems that make it quite difficult to identify a reliable next of kin for our patients. So the implications for ICU research. So as you can see, the consent process in ICU is quite complex and it's quite sensitive. Adhering to the ethical principles to obtain informed consent is very, very, very challenging at times. So we do have established ICU consenting models, and obviously provision or opt-out or waivers are really great. Our consent to continue obviously works well, and now we found that our e-consents and our verbal consent models work well in ICU. I suppose the ongoing areas of collaboration in a group of HREC is, we like to look forward to refining potential protocols to create simple picks for the patients, to support the increased recruitment numbers potentially. And also I think there's a really big role in HREC to harmonise and interpret the National Statement and Guardianship Acts so that we can regulate our consent process and ensure that our critical care and our ICU research continues in Australia. Thank you so much.
The dreaded mute button, hang on. Fantastic. Jen, thank you. Oh, start my video. Fantastic. Yeah, thank you for that. Are there any questions from what is clearly a really challenging, but you know, getting this right has really revolutionized the way we manage COVID, for instance. So incredibly challenging environment. Yeah, Bronwyn.
Thanks, Jennene. That was really interesting. We're doing a study at the moment, and it made your talk about communication made me think of this question. Did the impact of mask wearing affect the communication as well, for the listener and for the person communicating?
Oh, absolutely.
Yeah.
It's so difficult to lip read through a mask. And when my patients have got a endotracheal tube in, the lip reading and just the whole interpreting what they're saying to us is quite an important aspect of our nursing care. So yeah, we weren't able to actually do that effectively in the ICU environment.
Yeah, okay, thank you.
Any other questions regarding that challenging situation? The speed at which you responded, though, like, did you find that you couldn't recruit your numbers, or that recruitment was so? I guess the thrust of my question is the data for REMAP-CAP likely to be not flawed, but skewed towards English speaking and different populations to those that are actually getting sick at Liverpool?
I'd like to say that it wasn't skewed, because we made every effort to include this diverse population. That included getting transcripts in their languages. We had to use interpreters, like phone interpreters, which is really quite difficult. I didn't realise how difficult it was until we actually did it. And we also really tried to verify who was the next of kin. So that became a big process in terms of talking to our social worker and trying to actually find the next of kin, because sometimes actual next of kin was actually in hospital themselves. So it made it quite difficult to ring them up, but we made sure that we had those conversations, or tried to have those conversations to include them in the studies. So fingers crossed the data's good, and there's a broad spectrum of people that have been recruited.
fingers crossed. It's the best we've got. It's a rapidly changing virus, and that which worked at the start is less effective now, and vaccination rates are falling. So, you know, this war's not over at all. So it's everyone says the pandemic's over. No, our response to the pandemic is over. We're over the pandemic, but the pandemic's not over. And there's just a comment there and acknowledgement of the understanding the HREC and the Research Governance Officers provided. So thank you for that, and also a great slide for demonstrating visually all the challenges regarding obtaining consent with juggling balls in a fluid environment. Like, the patient may actually die. I don't think people quite realise that, you know, sometimes the survival rates are only 70% with a 30% mortality rate. In fact, surviving ICU is itself a risk factor. So look, very effective. You're in the cauldron there, literally, and so thank you for that. That, you know, is a really challenging. There's a lot of empathy for just how challenging that might be. Any further questions, comments, queries, criticisms, acknowledgement? I have one question about the picture. Like, how do you get the consent of the patient to actually take their photo?
Our consultant did that. I'll have to ask him.
Yeah, I was looking.
I'm hoping when the patient regained consciousness, he got consent.
Yeah.
But you can't see his face.
I can't see his face, but and I was looking to see if there was any name up on the.
No.
And there isn't. So I thought, you know, I was just being, well, picky. So well done.
Thanks.
Thank you very much. All right. So on that, we'll move forward, and I think the last one is I'm just going to go to my cheat sheet there, Bronwyn. Bronwyn, were you at the Vivid?
Yes.
With that really cool 3D printing of food?
Yes, that's right.
Is that your work? That was so cool.
Oh, thank you. That's lovely.
Yeah. Everyone should have gone, and everyone should have seen that. But and if not, they should, you know, suss it out.
I have a recording of it if people do want to see. It was a segment with Maggie Beer about nourishing health in older people.
I think that was
well-being.
And it's just about equity of access to food, and the difference between your 3D food and just the ice cream scoop. And I kind of got it. The picture tells 1,000 stories. But this is a different. Which is complexity and consent when there is disability communication and inclusion. And please, Bronwyn, take it away.
Okay. Well, thank you very much for the opportunity to speak today about this issue. And I found some points from Kirsten and Jennene that really echo with this group of people who have disability and communication impairment. So I'll start off as well with an acknowledgement of country, and today I'm in Newcastle, so I'll acknowledge the Pambalong clan of the Awabakal people and all the First Nations people of the lands where you're attending from today. I also acknowledge the Gadigal people of the Eora Nation, upon whose lands UTS stands and where all my work happens, and acknowledge elders past, present and emerging, as well as any Aboriginal and Torres Strait Islander people here today. Now, I'll just preface my talk with a large national project that UTS was one of the partners involved in recently. And because I'm talking about disability, this is something that all ethics committees, I think, need to know about. It's the National Disability Research Agenda Project. And recently we did an agenda setting exercise across the nation. So I'll tell you about the 4 reports that are open access, and that researchers really should be looking at these when they design research with people with disability. So the first one, is a review which just caught up the years since the last major review of disability research in Australia. The second one was a large survey. And this was an online survey asking people with disability and organisations and self-advocacy groups, workers, anyone in the field, about what should be on the agenda for disability research. And then the third one was more consultation. So the online survey was followed by interviews, focus groups, consulting with organisations they consulted with their members or their services recipients, and that's all summarised in that report, and then it's drawn together in a phase 3 report, which really tells the overall agenda that people are saying, people with disability and their networks. So that's a really important project. And that one of the questions in that final report was one of the questions asked was, if people could do one thing in disability research to improve the lives of people with disability in Australia, what would that be? And people could write anything in that section, in that question. And these were the 4 main themes in the answers. Research should be more inclusive, and much more inclusive than it currently is, of people with disability. So they're traditionally excluded from research because they're highly heterogeneous, they might not be fitting into control groups, etc. So it needs to be more inclusive, not only of participation, but also of the researchers driving the research. It needs to empower people with disability. So they should be driving the research questions and involved from the very beginning. So ethics committees could ask researchers, have you consulted with people with disability? So there's a question there, who have you consulted with? You want to see in that answer that they've consulted with some sort of organisation, group, self-advocates, people with disability about the research design. It should be accessible and inclusive so everyone can access the information. And just listening to Kirsten and Jennene, I'm struck by the fact that 45% of Australians do have some difficulty with literacy, with reading. And also there's people with different languages, and there's people very vulnerable, need simpler information. So we need to have accessibility. And I guess my talk covers a lot of accessibility. And this last one is, it should be useful. So distributed in ways that people with disability can access and use in their lives and their work. So it's not just enough to say feedback will be given, a summary will be provided, journal articles available on request, a seminar. Now it should be, how can I use this? I'll help translate it and help you translate into your policies, your practices, what will change into training, those next steps. That's also an ethical responsibility for the use of the research funding. And funds now do provide a bit more support for that. So the population, I'm talking about people with significant disability. So in the blue, in the centre of that figure, there's people with moderate, severe or profound disability. And around that centre circle is various characteristics. And I love the juggling, the hands with the juggling balls, but I'm trying to give you the same sort of complexity that they often have high support needs, rely on other people for information, they have less access to literacy, less access to the internet, to computers, they might have an intellectual disability as well, but they commonly might also have problems understanding and expressing themselves. So consequently, some of the conditions that might be associated also have multiple health conditions associated with them, like epilepsy or stiffness or all sorts of physical pain conditions. There's a whole lot of different conditions resulting in these disabilities. There's a high proportion of communication disability in these populations that impact on research participation. So they often are supported by family members or support workers. And support workers also have typically low levels of literacy and low health literacy. So they're a population that are at risk of missing out of the information that you're trying to obtain or give in informed consent. They could be actively excluded and they might not have access to recruitment information. So the opportunity to take part isn't as available to them. And there's obvious implications for simplifying information sheets and different methods of obtaining consent. And I've got a video later in my presentation that's an example of a video information statement for people with intellectual disability. My PhD student at UTS, Harmony Turnbull's researching the accessibility of health information written by allied health professionals. It'd be interesting to see what's the accessibility of information in their information statements for people with disability. And there's also lots of examples of adding visual supports to text. So if people don't read to understand, they've got the visuals that can be added to the text. So disability can affect both the process of consent plus the participation. So just as recommendations to most people in the populations should be, the consent should be multimodal. So not just relying on one avenue of information. And I think both Kirsten and Jennene talked about having a conversation and verbal explanation on top of the written explanation. You can use the teach back method where you might explain and see what can they tell you back that shows they really understand it. Is the person the one giving informed consent or somebody else? And who's going to be the one involved? But the person with disability should also be involved in the information exchange about it, because they've got a right to know what it involves for them. So how does disability impact on the actual taking part? So when you're in the ethics committee, you might consider, is there another way that populations with disability can be supported to take part so that they don't need to be excluded? And things like doing an online survey that the researcher might also find out, is someone helping you with this, or can someone else step through the online survey with you to help you with your taking part with the computer access? With in-depth interviews, can the person communicate directly for themselves independently, or with a communication assistant, somebody else there to support them, and often a support person. So we often need to also have an information statement for the role of the support person that outlines your role is to support them, not to provide your views, but to help their views to come out. So that's a really important thing about communication assistance. And often they need a bit of support just because they don't know you, they need someone familiar. It helps them to relax and take part in the study. And of course, it brings up privacy issues. So that's why they need an information statement and a consent form as well to keep things confidential. Then focus groups, they might need a support person to take part in a focus group. And the moderator needs particular skills in ensuring everyone has a say in that focus group, including people who need more time to respond, so that they're not talked over in the discussion and they get to have a say. Now, do they communicate with a communication aid, like a communication board or a speech device? Are they using it independently is the key question. So it might be, no, they do need assistance. So it's about acknowledging that assistance. And then if they've got unclear speech, so they have slurred speech after a stroke or Parkinson's disease and unclear speech, then is there a speech interpreter, someone who does understand them and can interpret for you because you're unfamiliar, you don't understand their speech? So we have had quite a few studies where there's somebody to help interpret the person's speech, but they do need to have something recognisable. It can't be completely unintelligible speech because there's no way of checking that the interpreter is actually saying what the person is saying. So it's the advice of a speech pathologist might be helpful. So we want to work out to what degree is the communicated message coming from the person with communication disability, and how will the researcher check on that? So that's their responsibility to figure out whose voice is it and determine the authorship of that message. So who's saying it when two people are involved? And sometimes you have to acknowledge it's two people involved, they both gave consent and they're co-delivering the message. There's other methods that people can use in research to take part, such as photos, videos to help stimulate the discussion, and not relying just on spoken language or understanding. So there's a lot of methods, research methods now for people with severe or profound intellectual disability, where their preferences or what they seem to enjoy or what they seem to think is inferred from their engagement with some activities. And there's quite a lot of research now that makes use of these methods, and it's quite helpful. So how can we look at criteria for inclusion for people in a study? That they should be able to communicate independently, even if an assistant is there to help communicate in the session. So the role of that person should be acknowledged. The person might need access to a communication aid to take part, like a board or a speech device or pictures or whatever. The study materials should provide relevant communication aids for inclusion. So, for example, in a study, there might be words and vocabulary used in the study that the person doesn't have on their communication board. So the study should really provide any communication supports for that conversation. And that takes a bit of preparation and consultation. And the researcher really should have some experience in communicating with people with severe communication disability or intellectual disability. So research teams need to include enough experts who've got some experience in that. And the research materials might need to be modified as well. So the actual tools that are used. Now, there's a couple of problematic practices in communication supports, and they're called facilitated communication and rapid prompting method. You might not have heard of these, but that's if somebody's holding the person's hand, elbow, arm, or other body part and guiding their hand to the alphabet board. And rapid prompting method is when people are holding the board and in the air and the person is pointing to the letters. Now, both of those techniques have not been shown to support the person's own voice. There's no evidence that it's the person's voice being used. So therefore, the researcher should build in some authorship testing to see whose voice is being used in those techniques. Now, if you have more questions about FC or RPM, I'm happy to address them separately because they are being used more in research and it is ethically problematic and complex. I'm just showing you briefly some examples of different methods of providing information. On the left, you'll see just the standard bullet points, lots of white space, relatively short sentences, not paragraphs of text, and that's just really an invitation to participate. The one on the right is what we call text with symbols. So it's not necessarily easier to read this text with the symbols, and some people have trouble knowing what the symbols mean. This is really more for helping a person have a conversation and be able to slow down what they're saying, and they can use the pictures to help support the person understand as the concepts go along. So that's just one more example. And there's software now that will do this automatically for people. And one of the things that came to mind when you were talking about translation is the use of AI, and generative AI now should provide some way of improving how we adapt our materials. On my slides, which I'm happy to share, this is a video format, and it's from Harmony Turnbull's PhD. And so in the slides, you'll see, you can go and see that in YouTube. The other thing that we're starting to use to help make materials more accessible is actually generative AI in the form of ChatGPT. Now, it's really experimental at the moment. I've used it for a couple of attachments that I've needed to make for ethics applications, such as draft terms of reference for expert panels and things like that. But what it might be really useful for researchers to do is actually simplify. So it's quite good at reducing word count. If you say, here's my information sheet, can you make it simpler, make it shorter, turn it into bullet points, use active sentences, all the things that researchers typically overlook. It's really helpful, and I would suggest people do start trying to use it for this purpose. Just give me the 5 main points. It will save a lot of time and increase productivity. You can also ask it to create a video script. So I've got a few examples. I told ChatGPT I wanted to make a participant information sheet easier to read, and was just getting it ready to know what I wanted. And it unprompted gave me 9 quite useful points about making my information more accessible, which if followed would help. So now I gave it a full typical information sheet, like you said, 6 pages or whatever. And it's done some interesting things that an ethics committee might still not be happy with. So it would need editing and it would need fixing, but it could assist people to make their information sheets simpler. Then there's a video script making. So for example, I want to make a video summarising this so that people can listen and see information as well, not just read. And so it's suggesting some scenes, some narration, and you can take it and change it if it doesn't suit. So that's all I'll cover today, and I hope it's been interesting. But if you have any questions, I'm happy to take any now or by email.
Thanks, Bronwyn. That's I found that really useful and stimulating and helpful. And Merrily, feel free to jump in. And
I won't, but I'll just point out we have a question in the chat that we might want. We're running out of time. We might want to.
Are we? All right. Well, then we'll go to that. And
I can let you know what it is. It was to Kirsten from Danielle. So in instances of genomic studies where participants do not wish to know if there are incidental findings, how is consent managed? And then she talks about some organisations excluding people unless they're willing to receive the results, and if they don't have a regular GP for the findings to be communicated through.
An excellent question, and probably the million-dollar question that we think about constantly in genetic testing and genomics. Look, unfortunately, there's kind of no standardized approach to incidental findings. So incidental findings, just to explain for people who don't know, when you're doing genomic testing, so large-scale genetic testing, because you're testing lots of genes all at once, there is a small but not 0% chance that you may stumble across something that is completely unrelated to the reason for doing the test, but I guess has health implications for either the person having the test done or for wider family members. So an example of it might be, you're doing testing on a child to find a diagnosis for their condition, and you stumble across a genetic variant in a breast cancer gene, for example. That would mean that that child would grow up with an increased chance of developing breast cancer later in life. Now, I guess, unfortunately, at the moment, it really is down to each individual lab's discretion as to whether they report these findings back or not. So some laboratories will filter out adult onset conditions if they're doing testing in children, for example. Some laboratories will sort of do an all or nothing approach. There is no uniform, either in research or clinical testing, sort of consent process for this. And I guess as a genetic counsellor, what I would like to see in the future is that there is a standardised approach where patients and families are given the choice as to whether they want those types of findings returned back to them. Unfortunately, it is quite labour intensive from a laboratory perspective, but also from a genetic counselling perspective. I think the genomic literacy of the general population is not particularly high. And so I guess explaining those sorts of concepts and what the risks and benefits are, that would be quite a significant conversation for each family to have to speak to them about. But certainly, I totally understand where you're coming from, and particularly research projects that offer genomic testing and sort of say, well, either you agree to have all incidental findings back or you don't participate at all. That's probably not an approach that I would be comfortable with, but we are in sort of this grey area of genomic testing and research at the moment.